I'm a big fan of the GAIA CLL13 study. I think the design of it really helps us answer some important questions in CLL. I do think that we have a lack of relapse refractory studies right now, but it's nice when you do an initial treatment study like that one because you get a clean look at what's happening to a more uniform population of patients or people at the same in the same place with their CLL. I think the most interesting thing that came out of that study, or one of the most interesting things, is that they had venetoclax with Rituximab and then venetoclax with Obinutuzumab as two different arms. And the venetoclax dosing was the same. And you actually see much better results with the Obinutuzumab compared to Rituximab, which is very clear that the antibody is, one, really adding something. Again, this is like a fixed duration venetoclax strategy. So you can really say that Obin is adding something definite there. And really showing that the Obin is better than Rituximab. So that's really led me to question in a relapse refractory setting where, of course, the Murano study led to the approval of Rituximab with venetoclax with a 2-year venetoclax dosing. Really led me to question whether or not we should be using Rituximab with venetoclax in previously treated CLL patients. And really just maybe we should be using Obinutuzumab even though that's not how it was studied in that setting. So I thought that was super interesting. The other thing that I think was quite interesting from that study was just that they had a 3-drug arm where there was Ibrutinib included. So it was venetoclax, Obinutuzumab, and Ibrutinib. I think there's a lot of questions whether 2-drug or 3-drug is better. And in that arm, Ibrutinib was continued past the 1 year, then Obin in a fraction of patients. So it's a little hard to interpret the results as cleanly as just a fixed duration. Because I think there's a lot of questions still in the field about an MRD-guided or response-guided discontinuation of these kind of combinations. But you can see it looks like the 3-drug is actually resulting in some improvement in outcomes for the patients and PFS at a longer follow-up. So I want to see if that ends up coming apart from the Ven-Obin as we get farther into seeing the results from this study. I think in CLL, our patients do so well now, especially with frontline therapy, that it takes longer to really see the results we need to from these studies. And I think that's why we try to use surrogate endpoints like MRD negative status just so we can make sure we offer our patients what we think will be our best therapies now. But there is a high amount of value in making sure that we continue to follow up results of these bigger studies. I started by talking about very long-term follow-up with Ibrutinib studies. So this GAIA CLL13 is another one where I really look forward to seeing what happens in the future with that. So I think we've learned a lot already, but I hope that we continue to see updated results from that because I think it will really inform our practice.